Дорогие друзья, у нас сегодня наш большой друг, с которым мы знакомы уже очень много лет. Первый раз мы познакомились с доктором Франко Сервадеем в 1989 году в Нью-Дели во время Всемирного конгресса нейрохирургов. С тех пор мы постоянно участвуем в разных конференциях, мероприятиях. Франко неоднократно принимал участие в наших конгрессах. Сегодня он в гостях вместе со своей супругой, красавицей Констанс. И у нас сегодня в гостях научный атташе посольства Италии в России Проф. Я попрошу приветствовать наших итальянских гостей. И thank you very much for coming to our conference. It's a great honor for us. Thank you. And I would like to ask Franco to come to tribune, and I ask my colleague to say some words about Franco. Please. Глеб Данилов.
Глубоко уважаемые коллеги, профессор Франко Сервадей, руководитель нейрохирургической клиники университетского госпиталя города Пармы в Италии. Доктор Сервадей окончил ординатуру, резидентуру по неврологии, затем по нейрохирургии в старейшем университетском городе Европы, итальянской Болонье. Работал в должности профессора в университетских клиниках итальянских городов Анконы, Катании, Чезены. Профессор Сервадей был членом исполнительного комитета Европейского консорциума черепно-мозговой травмы, был официальным национальным делегатом и председателем комитета по черепно-мозговой травме Всемирной федерации нейрохирургических обществ, а также членом избранной группы экспертов организации Brain Trauma Foundation. Работы профессора опубликованы в 150 журналах с высоким импакт-фактором, нескольких монографиях и главах учебников по нейрохирургии. Профессор является обладателем многочисленных наград за заслуги перед нейрохирургией. Профессор Сервадей был директором комитета по нейротравме итальянского региона Эмилия-Романья, возглавлял службу оказания помощи пациентам с нейротравмой в этом регионе, участвовал в разработке клинических руководств в составе Национальной итальянской комиссии, был организатором и главным куратором телемедицинской системы региона Эмилия-Романья. В настоящее время профессор возглавляет нейрохирургическую клинику и клинику неотложной медицины университетского госпиталя Пармы. So, ladies and gentlemen, please welcome Professor Franco Servadei.
First of all, I have to thank Professor Prof and Professor Conovallo for the invitation and the honor for being in the Burdenko. My first meeting with Burdenko was 1982 when I was a young neurosurgeon in training, and Professor Conovallo gave a lecture for the trainees of the European courses. It was a very great experience with the numbers that Professor Conovallo explained us. And there, my knowledge, as Alexander told you, with Alexander Potapov started in 1989. This is a congress in Bologna, 1990, where we had experienced a discussion, a round table, with, you see, Alexander Potapov, Larry Marshall, Graham Tisdale, and this is Professor Potapov's experience with the Armenia earthquake and with the rescue of the brain-injured people in Armenia, 1990. So I would say that it's a long time that we know each other. I had the topic of the evidence-based guidelines together with the topic of the personalized medicine. I tell you that in trauma I didn't think I have to learn something, but now I learn that we can personalize the cure of the patient. I have studied to produce. Obviously, this is the first producing guidelines which were produced by the US. Both myself and Alexander Potapov took part to this production of these guidelines. Is it guidelines something new? This guy is a soldier, a doctor of the Roman army, called Aulus Aurelius Celsius from Rome. And he was living 25 years, he was born 25 years before Christus, and he lived at the time of Tiberius Emperor. And he is quoted by Seneca. This guy wrote a book, let's say at that time it was not a book. Anyway, he wrote a summary of the medicine at that time, which is called De Medicine. And in this book, De Medicina, our friends from UK, from Oxford, discovered that Celsius already wrote guidelines how to treat head injuries. If the patient is senseless, then it's a bad sign. If the patient is bleeding from the nose or ears, or vomiting, or he has a spasm, or he cannot see, then it's a bad sign. So even at the Roman times, the colleagues from Oxford say we spend thousands of pounds to pay for this guideline. It was enough to translate from Latin because the guidelines were similar to that. We know that if we want to speak about evidence-based medicine, we need to grade the papers 1, 2, 3 levels. Obviously, we have to see when we have a standard, a guidelines, an option. So accordingly to the different type of treatments, we have different type of guidelines or options. The US guidelines are 14 topics, 3 standards, all negative. Don't use hyperventilation, don't use glucocorticoid, don't use prophylactic antiepileptic drugs, and 8 guidelines. These are the countries which adopted the American guidelines. You see that also Russia, we had a paper from Alexander in 2006, were adapting the American guideline to the Russian situation. But we have to learn something. Guidelines may be wrong. The first set of guidelines say that the target for cerebral perfusion pressure management was 70 millimeter of mercury. This was wrong. And after 6 years, it was corrected to 50. What does it mean? That for some time, we use norepinephrine to keep CPP higher than 70, and we didn't do the best for the patient. So we need to know that the guidelines may be wrong. It's not a Bible. It's not something that is written in the stone. Surgical guidelines, you see, these are guidelines for penetrating head injury published in 2001. Alexander Potapov and others were the writer of this paper. I was the only European to take part to the American group to write the guidelines for the surgical management of brain injury. So we have surgical guidelines for the management, but we have a big problem here, obvious. We only have class 3 papers. So if we want to operate someone in brain injury, but also in many other parts of neurosurgery, we only have options. So operating is not led or driven by high-quality papers. Look at this. For instance, if we have a hematoma like this, which is going to kill the patient within minutes if we don't operate, we don't have evidence-based medicine. So you see that the comment from clever American colleague was also ranking surgical evacuation of this hematoma as an option is consistent with the guidelines methodology, is not be consistent with real life. So what is written in guidelines may be not working in the real life. So if we don't have evidence-based, because it doesn't always work, what can we do to better target our therapies? This is from diabetes care, and is state-of-art for personalizing medicine, which is right for brain as well. Every patient has a genetic, a pathophysiological, a phenotypic, different aspect from the others. So a patient is a person, which is different from all the other ones. We need to target better our therapy. This is a paper from Alexander Potapov telling you that also in trauma, the genome of each patient may predict the outcome as well as the severity of trauma. Look at the study that it was done with apolipoprotein and gene polymorphism, which ended up that patients with a different genetic attitude, with different reaction to trauma, especially for neurotransmitters, apoptosis, oxidative stress, regeneration, are different concerning outcome. And this is also Jeff Manley from San Francisco, who tells us about the same. We are trying to find a specimen, biomarkers, which can tell us in the blood of the patient how it can be, how severe is the trauma and which is the outcome. We are not yet at the point in which we have it. We don't have it yet. But this guy, which is an Italian working at the veterans, got $600,000 with personalized medicine in traumatic brain injury. So the section of personalized medicine in traumatic brain injury is important. How can we target better our therapies? There has been a lot of discussion about monitoring of intracranial pressure. We think, many of us, we think that we have not personalized enough the treatment of intracranial pressure. These are the guidelines which basically tell you that everyone with an abnormal CT scan should have a monitor of intracranial pressure. Maybe true, maybe good, but the problem is if we measure intracranial pressure, when we treat it, when we decide that we need to lower intracranial pressure, all the cutoffs are at 20 millimeters of mercury. But as you see, also in the guidelines, it says that if ICP is not going parallel to clinical and radiological findings, maybe we have to think about. So this is very much important in the real life. We need to have a complexity of measurements. This is difficult, but it is what we do in head injury. We don't treat the patient, we increase sedation, we draw CSF drainage, hyperosmolar, mannitol, hypocapnia, hypothermia, barbiturates, and decompressive craniectomy in stages. See here, only level 3, except for this hyperosmolar therapy and for barbiturates, where we do have a level 2. No one is level 1. So what we do every day has not a good level of evidence. There are quite a number of papers in favor of a treatment with a cutoff at 20 millimeters. This paper is an old paper from 1979 showing that if the patient have a low pressure, like here, they have a better outcome than patient with a high pressure. Or, in this paper, that if we aggressively monitor intracranial pressure and treat pressure, the patient do better. Like this is mortality, patient treated with high intensity and low intensity. These are doing much better, lower mortality. And this also is telling you the same. If we have an intracranial pressure monitoring, everything is working better. But there are other papers which tell us doubts about the utility of treating ICP with a cutoff of 20. This is the first paper from Netherlands, Kramer, from Utrecht, Netherlands, telling us that if we compare two populations, one with ICP monitoring and the other without, the patient without ICP monitoring do better, which was not accepted by the community. There was a lot of reaction to this paper. Then, 2008, an American paper telling us ICP monitoring, according to the Brain Trauma Foundation criteria, is associated with worsening of survival. Worsening. We need a study, a prospective study, to show if it works or not. This is the prospective study, which was done by Randy Chestnut, but not in U.S. It was funded from U.S., but the study was done in South America, particularly in 3 countries of South America, Peru, Colombia, and Ecuador, and Bolivia, 4 countries. And the study showed that with or without ICP monitoring, the outcome of the patient were similar. We have to notice that this is true in South America. We don't know about Europe or US or Russia. It's typical of this area because the monitoring was paid by the study. They usually don't use the monitoring in this clinic. So they may be not expert in treating ICP, but this is also impressive. So the conclusion of Randy Chestnut is that the role of ICP monitoring will then be less of a holy grail approach to keeping pressure below 20. So we need to personalize the treatments. And why do we need to personalize treatment? Because the patients inside the brain have pressure, but they also have cerebral blood flow, autoregulation, metabolism. So the outcome is not only driven by the pressure, by a magic number, it's driven by many other things. This is what we can monitor for head injury. Look at how many things we can do. We can do cerebral blood flow, we can do PTO2 pressure, we can do neurodialysis, microdialysis. We can do a lot of things. We can get more information about our patients. And this is also a paper from this clinic, telling us that if we combine ICP, intracranial pressure, and cerebral blood flow, this is better working than only counting on intracranial pressure. So these are studies done here, showing that we need to combine cerebral blood flow and intracranial pressure, not only intracranial pressure. This is a confusing chaos, but this is reality. This is from Randy Chestnut, who show you the pathophysiology of head injury, the treatments, and the toxicity. You see which chaos is here. How can we say that we cut off ICP or 20 and we cure the patient? Look at how much we have to deal with a lot of toxicity and a lot of treatments. The patients can be very easy. This patient is very easy. Small contusion, break of the frontal sinus, pressure, intracranial pressure goes up. We repeat CT scan, big contusion. We operate the patient. Very easy. I mean, things are going. But what about this patient? This patient had ICP monitoring. Pressure was 15 between these 2 CT scans. So the patient had a huge hematoma with no movement, no increase of intracranial pressure. So which is the conclusion about intracranial pressure? Then I will speak about decompression and finish. Which are our conclusions? We had a consensus conference in Milan, which was organized by Nino Stocchetti from Milan University and by myself. And you see that here in the panel there is people from Hungary, US, Greece, Sweden, UK, Greece again, Norway, or the Netherlands, France, Israel again. So we do have an international conference in Milan just to decide when to put an ICP monitoring, and we decided that if the patient has a normal CT scan or very small petechia, we don't monitor ICP because this patient like this is not going to have an increase in intracranial pressure. The problem is this, that you have studied much better here at the Burdenko with the tensor imaging, that's typical of diffuse axonal injury. But if we have a contusion, then we monitor ICP. So we have to target better the monitoring of ICP. It's not for everyone, it's just for the patient that need to be cured with intracranial pressure. What about bone decompression? Can we personalize the decompression and better target it? This is a very hot topic now. When to decompress a patient? First of all, we have two types of decompression. One is the unilateral decompression for hematoma evacuation, which is this one. You have an acute subdural shift of the midline, large shift. You operate, you take off the subdural, and you decompress the patient. This is called primary decompression. There is no ICP monitoring because you don't have time. The ICP is after the operation, not before, because you bring the patient to the operating theater. Or, in this case, you have a huge contusion, and you do the same. We operated the contusion, and we took off the bone. Then we have the secondary decompression, in the case of bilateral or diffuse lesions. And you see it here, this patient is already in the intensive care unit 12 days, and you see that now he's here when we operate, so it's 6 days. You see that he has contusions, but the pressure goes up. After 6 days, ICP 40, so we bilaterally decompressed the patient, and he did very well. So we have two types of decompression. There are trials. You see that these are the trials on head injury. On decompressive craniectomy, we have one trial who is finished, the DECRA study. Rescue ICP is finished, and we wait the results. The rescue ASD and the METRA, this is Italian, this is UK, but we put them together. They are just starting now, these two studies. This is the STITCH study on contusion, the DECRA and the rescue ICP, brain swelling, and the rescue acute subdural hematoma, huge acute subdural hematoma. So these are three different studies, completely different studies. What about the study, the DECRA study, which is basically Jamie Cooper and Jeffrey Rosenfeld from Australia, is an Australian study, even if most of the patients are from Arabia, from Saudi Arabia, but the study is an Australian study. And the results of the study are very important to all of us. This is intracranial pressure before and after craniectomy. No more pressure. The pressure is below 15, normal, the one we have in this room. So the study was able to decrease significantly the pressure, but the outcome was worse. We are only talking about diffuse injury. We're not talking about focal injury. We are talking about having a cutoff at 20 millimeters of mercury that we won't decompress the patient in this condition. But anyway, this is clear that if we decrease the pressure, not always the patient do better. And this is the rescue ICP. You see is a combined effort from the University of Cambridge and many others, like the European Brain Injury Consortium and many others. And these are the inclusion criteria, which needs ICP over 25 between 1 and 12 hours, an abnormal CT scan. If the patient is not working well, then it's complicated, but I will go through. If the patient is doing bad, then he has two possibilities. One is barbiturates, and the other one is surgical decompression. and the crossover is permitted. So if this patient is not doing well, it can be operated and vice versa. The study is finished at the end of March. 400 patients have been enrolled in this study. The follow-up will continue for 2 years, and the data, we are waiting for the data. And this is the new study between, there are 7 universities. Our university, the University of Cambridge, is ruling the study, and is in acute subdural hematoma. It's only in acute subdural hematoma. And it's, how do we do it with acute subdural hematoma? We randomize patient to evacuation of the hematoma only, or evacuation plus hemicraniectomy. This is the study. We can better target decompression. What is, in conclusion, about decompression? Evidence is developing. We don't have evidence. There is no class 1 evidence in favor. The DECRA study was negative. The rescue ICP, late 2014, early, I would say 2 or 3 months yet. The rescue acute subdural hematoma is already started in UK, and we will start it in Italy in 1 month. The indiscriminate use of decompression is not appropriate in view of complication, and this is a statement that we did together with a group in Cambridge. So already in 1979, Professor Cooper from US he said decompressive craniectomy cannot cure unsalvageable patients, providing them a reasonable quality of life. And you know that this is, in Italy we have 4,000 patients, 400 in persistent vegetative state. 66% of them in one stage have been decompressed. So we have to think very much about what we do with decompression. That's the finish. Can we also personalize bone reconstruction after decompression? Yes, we have many materials for reconstruction. We have the bone, autologous bone. We have metals, we have polymers like polymethyl methacrylate or PEC. We have ceramics like hydroxyapatite. So we have many possibilities. Usually, we all now use 3D reconstruction with stereolithography. If we put back the bone, you see, the bone of the patient is the more convenient because it doesn't cost anything. It's very good. It's autologous material, but 25% is reabsorbed. You see it here. 25% of the bone is reabsorbed, which is a disaster. But in children, this is the German paper, in children, young children below the age of 14, 54% need a new cranioplasty. So what we do is, if the patient is young, like this, 9 years, we don't put the bone back because the bone is 50% of possibility to be rejected. In this case, we use hydroxyapatites, but you can use whatever you want. This is ceramics. But if you need immediate protection because this patient had aggressivity and behavior abnormalities, you cannot use ceramics because ceramics, they will break at the beginning before osteointegration. So in this case, we use PEC. This is PEC. Or you can use PMMA. So it's easy. You have different possibility to reconstruct the vault. So just to finish, one thing which is very much important. We need evidence-based and we need guidelines. But we also need to be in the right time of the life and of the science. Look at this graph. This is mortality. Here, one thing was done. Again, here and here. You understand it clearly that you can lower the mortality very much if you do something here that you have done. it is clear to everyone that you could reduce mortality by doing one maneuver, one operating thing here, and the mortality went down. Everybody in this room understands that I can cure this disease by doing something. This is Vienna General Hospital maternal mortality. This is the maternal mortality in these years, in these days, 1846. By washing hands, only washing hands, the mortality went down. But Semmelweis was kicked off, was removed from his position after publishing this data because a committee of doctors, academic doctors, say, you are kidding. It cannot be true. There is nothing to do with washing hands. So even if you have a good evidence, if you are too early, it's not enough. So just to finish, I invite all of you to the interim meeting of the World Federation, which will be in Rome next year in September. This is Rome. And these are the emails where you have to go. You just go to the interim meeting of the World Federation 2015, and these are the contacts. You all are very welcome in Rome. I am one of the president. I am the president of a scientific committee, and I welcome all of you contribution from Russia to Rome. Thank you very much.
Thank you so much, Franco. I would like to tell you that it was a great lecture. It's a great honor and pleasure for us to listen to this lecture. And I would like to announce the decision of our scientific committee of the Institute of Neurosurgery and to give you the position of the honorary professor of the Burdenko Neurosurgery Institute. And I asked Professor Academician Konovalov to give you the diploma and the special mantille from my colleague. And music, please. Я еще раз хочу поблагодарить нашего гостя, господина профессора, почетного профессора Института нейрохирургии, в связи с тем, что он одновременно является президентом научного комитета следующего в сентябре Всемирного конгресса нейрохирургов, пожелать ему успехов. Вчера мы с ним обсуждали огромную ответственность, которую он несет как президент научного комитета, и он попросил Российскую ассоциацию нейрохирургов предложить в каждый комитет по всем разделам нейрохирургии делегировать по одному российскому нейрохирургу для участия в работе научных комитетов этого конгресса. И еще раз поблагодарить нашего гостя из посольства Италии, для нас господин Петро Фрей за участие в этом мероприятии и супругу Констанс за то, что вы приехали вместе со своим супругом. Всем огромное спасибо. До завтра. Завтра в 10 часов у нас продолжается наше мероприятие. Спасибо большое всем.